And I'll talk about liver cirrhosis and its medication nadolol. I'll first start with the pathophysiology of the medication of the disease, and it's an irreversible inflammatory and fibrotic liver disease. It's a widespread of fibrosis, that is a scar tissue on the liver, and the conversion of normal liver architecture to abnormal nodules. So there's nodules on the liver, and this picture shows you, it starts with the liver fibrous, and then it becomes too much, and then the fibrous prevents blood flow to the liver. Thus liver becomes hypoxic and receives poor nutrition, leading to hepatocyte dysfunction. Hepatocytes are the cells of the liver, so there's a dysfunction there, and the liver cirrhosis brings about complication. One is portal hypertension. This is when the because of the fibrosis, there's an obstructed portal vein, that's leading to an increased venous pressure. And from that portal hypertension, the body forms collateral circulation. Those are the varices to bypass the liver, and they're formed in the esophagus, abdominal wall, and the rectum. And another one is ascites and edema, fluid accumulation in the peritoneal and abdominal cavity. So, and that's why you see people with liver cirrhosis having a protruding abdominal. And the fourth one is hepatic encephalopathy, and this is high levels of ammonia in blood. It brings about neurotoxic. There's high levels of ammonia because there's an obstruction, and so blood rich in ammonia does not go to the liver to be converted to urea. So from the complication, I'll focus on my top key assessment. Those are, for example, to make sure that the person doesn't get hepatic encephalopathy, I'll check the LOC and endo times 3, as this is neurotoxic. And the other one is lab values and hemoglobin and INR to prevent risk of bleeding, as varices are vulnerable to rupturing. And I will also check for the ammonia if it's elevated to check the hepatic encephalopathy. Vital signs: high heart rate and low blood pressure, risk of bleeding, and low respiratory and SpO2, ascites, as that protruding abdominal can stand on the lungs. And then I will focus on the mechanism of action of the medication. This is a non-selective beta-adrenergic blocker, as it blocks both the beta-1 and beta-2 cardiac receptors, and it blocks the renal and beta-1 receptor. So from this, I'll focus on my top 3 concepts for this medication. This is the perfusion. Perfusion, and by this medication by blocking the cardiac beta-1 and beta-2 receptors, nadolol reduces the force of contraction, cardiac output, and heart rate, thus reducing the portal hypertension. Next is elimination. By blocking beta-1 receptors, nadolol suppresses renal secretion, which then reduces angiotensin II, and which thus increases the excretion of sodium and water. And sodium and water, so the person might be peeing a lot. And another one is fluid and electrolytes. Fluid and electrolytes, because of the inhibition of angiotensin II and sodium, the sodium levels, there's low levels of sodium and water because there's high increase of excretion, and then there is a hyperkalemia because the body is keeping potassium. So before I give this medication, I will assess the blood pressure, as it can cause, and so that I can hold the systolic blood pressure if systolic BP is lower than 90, and I'll check the pulse. If it's lower than 50, I will hold. And after administering, I will check the BP, as it can cause hypertension, heart rate, as it can cause bradycardia, and I will monitor the ins and out, as it can cause fluid overload. So the person might be at risk of for heart failure. So, and before then, I will assess and indicate that the drug is working effectively and decreased. This is decreased and decreased BP as it's connected to the complications. So it decreases the portal hypertension and it decreases ascites. So to make an assessment that the drug is not working effectively, that is high blood pressure, because it's supposed to decrease the portal hypertension and weight gain, as it's supposed to decrease ascites. But if there's a weight gain, it's not working well, and the person might be at risk for heart failure. And bronchoconstriction can cause dyspnea, wheezing, and especially exasperating the person with asthma. And this arrow shows linked ideas, because from knowing the mechanism of action of the medication, I will know the system that it affects, the priorities, and this one. And then, from knowing the pathophysiology of the disease and the complication, I will know what to assess and what to focus most on. Thank you.